The limbic system consists of the limbic lobe and its many connections. It is a set of 3 arcs situated deep in the brain containing both gray and white matter. Phylogenetically, it's a primitive part of the brain, and it has a central role in memory, learning, emotion, neuroendocrine function, and autonomic activities. Basic human things that we do. That makes us human. Diseases that involve the limbic system include epilepsy, congenital anomalies, dementias, and psychiatric disorders. Everyone wants to attain wisdom. And in this article by Meeks and Jesty, they stated that wisdom may involve optimal balance between functions of the phylogenetically more primitive brain regions, limbic system, and newer ones, prefrontal cortex. So the limbic system has a central role in us attaining wisdom. Let's take a look at the anatomy of the limbic system. Again, it has the 3 arcs that I've colored in blue, yellow, and red. The outer arc, well, first of all, on the image, this is a mid-sagittal section going through the corpus callosum and those midline structures. And then on the lower part of the diagram, it slants off into the temporal lobe to capture the structures in the medial temporal lobe. The outer arc in blue, the limbic gyrus, consists of the subcallosal area. The subcallosal area contains many little septal nuclei that have a critical role within the limbic system. And one of those nuclei has a role in Alzheimer's disease, being a center for producing acetylcholine and distributing that to the rest of the limbic system. The subcallosal area is continuous with the cingulate gyrus, and that continues on in an arc, and finally entering into the parahippocampal gyrus. The amygdala is also part of the limbic system, situated adjacent to the parahippocampal gyrus and the hippocampus. The middle arc, known as Broca's intralimbic gyrus, consists of the paraterminal gyrus that is situated between the subcallosal area and the anterior commissure. The paraterminal gyrus is continuous with 2 bands of the indusium griseum that courses over the corpus callosum, continues on posteriorly, and is continuous with the tail of the hippocampus. And that continues as the body and the head of the hippocampus. So the tail of the hippocampus does not end. It continues to the indusium griseum to communicate with some of the more anterior structures in the brain. And then the inner arc consists of the alveus and fimbria, the major efferent fibers coming from the hippocampal neurons. And the fimbria continues posteriorly, forming the columns of the fornix. And that extends up beneath the corpus callosum, the splenium of the corpus callosum, and anteriorly along the inferior edge of the septum pellucidum. More anteriorly, it divides into 2 bands, the anterior band going to the subcallosal area to assure good communication between the subcallosal nuclei and the hippocampus. And the posterior band continues on inferiorly to join the mammillary bodies. So that's the anatomy of the limbic system. Want to take a closer look at the anatomy of the hippocampus, because that is a critical function or a critical structure in the temporal lobe epilepsy. This diagram is of the medial aspect of the left temporal lobe. On the inferior surface of the temporal lobe, the collateral sulcus is almost always visible on the images. So if you identify the collateral sulcus, that shows the start of the parahippocampal gyrus. The parahippocampal gyrus continues onto the subiculum, and that continues with the cornu ominous of the hippocampus. Cornu ominous divided into 4 parts, CA1, CA2, CA3, and CA4. And that also connects with the dentate gyrus, another part of the hippocampus. As you can see, the hippocampus bulges up into the temporal horn of the lateral ventricle. On top of the hippocampus is the alveus and fimbria, again, the axons, the efferent axons coming from the hippocampal neurons. On top of that, there is the layer of ependymma of the lateral ventricle, and then the choroid plexus in the inferior aspect of the ventricle. The temporal horn is above and lateral to the hippocampus. More medially is the choroidal fissure for entry and exit of the arteries and veins. One other structure is the hippocampal fissure. And with development of the hippocampus and the folding and twisting of the hippocampus, there is that little fissure that's still remaining in the adult hippocampus. And very commonly, little collections of CSF get trapped within that hippocampal fissure, and those can be seen on the images of normal patients. And it's just to be important to recognize that as being normal structures rather than something pathological. On this coronal anatomic section, through the temporal lobe, again, there is the collateral sulcus. Now we are looking at the left temporal lobe, collateral sulcus, and the perihippocampal gyrus, gray matter structure, continuous with the subiculum and the cornu ominous, arcing around and interconnecting with the dentate gyrus. The white matter, the alveus and the fimbria on top of the hippocampus, choroid plexus, and the temporal horn above the hippocampus. Important structure for recognizing anatomy on the MR images is the superficial medullary lamina. Again, white matter that is covering the subiculum, and extending along the cornu ominous, which helps give us definition on the MR images to distinguish the gray matter from the white matter. So it's an important structure to identify when we look at the images. On this Netter diagram, just to show the relationship of the hippocampus and the temporal horn to the optic tract and the tail of the caudate nucleus. Here's an MR image, T2 weighted image, collateral sulcus, perihippocampal gyrus, and one can see the gray matter component that's a little brighter than the white matter component of the perihippocampal gyrus. Continuing on to the subiculum, cornu ominous, swinging around to the dentate gyrus. And notice that very thin dark band representing the superficial medullary lamina that follows the cornu ominous in the hippocampus and shows us the internal architecture of the hippocampus. And that band should be present in a normal hippocampus. When you develop disease, sclerosis of that hippocampus, that internal medullary lamina often disappears. On a high-powered photomicrograph, just showing the subiculum and the region CA1, CA2, CA3, and CA4, and the dentate gyrus. This pie chart shows the causes of epilepsy. There are many causes. Anything that irritates the cortical neurons can be a source of epilepsy, and that irritation can be hemorrhage, it can be sclerosis, some kind of a pathological process that's affecting the neurons. Importantly, notice that about a third of epilepsy is due to hippocampal sclerosis, and specifically temporal lobe epilepsy. And then there are many other causes that are listed, many other conditions that can cause epilepsy, and we'll take a look at many of these in this lecture. This is our MR imaging protocol. We get the axial susceptibility weighted images or gradient echo images to look for hemorrhage, because hemorrhage can certainly irritate cortical neurons. We also get the axial fast spin echo T2 and the flare images because those are most sensitive for picking up non-hemorrhagic lesions of the brain. And then specific to the temporal lobe, we get high resolution coronal T2 and flare images, no more than 2 or 3 millimeters in thickness. And these images are angled perpendicular to the hippocampus. And they give us the best look at the hippocampus to look for that hippocampal sclerosis. Gadolinium is optional. If it's chronic epilepsy, we do not give gadolinium. In a patient with new onset epilepsy, then we probably would give the gadolinium. And this illustrates how we get those images. The tech identifies the hippocampus on a sagittal view, and then the images are oriented perpendicular to the hippocampus. And again, they're 2 or 3 millimeters, and so there are several images that we see through the hippocampus that give us a good look at all portions of the hippocampus. And on these coronal T2 weighted images, you can see the head of the hippocampus and the digitations identifying the head of the hippocampus. And then as we go further back, you can see the body of the hippocampus. And again, note that superficial medullary lamina that shows us the internal architecture of the hippocampus, and extending back into more of the posterior body of the hippocampus. On that sagittal view showing the hippocampus, note that the temporal horn is on top of the hippocampus and also extends anteriorly in front of the hippocampus. And anterior superior to the temporal horn is the amygdala. So the amygdala is separated from the hippocampus by the temporal horn. One more structure. I have a rectangle, a red rectangle on the right parahippocampal gyrus, just to show the approximate location of the entorhinal cortex. The entorhinal cortex is a very small area, but very important area of the limbic system. It is the entry point for olfactory stimuli that come into the limbic system. It's also a critical anatomic region that is affected very early on in Alzheimer's disease. Studies have shown that neuronal dropout in Alzheimer's disease seems to occur very early or first within that entorhinal cortex, and it's just a part of the parahippocampal gyrus. Some axial T1 weighted images, just to look at the white matter one more time. If we start up anteriorly by the head of the hippocampus and continue on posteriorly, you can see the alveus and the fimbria. And that extends into the crura of the fornices. And then if we come back more anteriorly, you can see the fornix and the columns of the fornix, and that continues anteriorly, dividing into 2 columns to go to the subcallosal region and the mammillary bodies. In cases of hippocampal sclerosis, severe hippocampal sclerosis, one sign is to look for atrophy of the fornix on the side of hippocampal sclerosis. Hippocampal sclerosis is the main topic that we will discuss for temporal lobe epilepsy. It is characterized by 30 to 50% neuronal depletion. It's most prominent in the CA1 region of the hippocampal body, a relative sparing of CA2. Prominent involvement of hippocampal body, second involved is the tail and then the head of the hippocampus. One theory is that with the neuronal dropout, there's loss of inhibitory interneurons, and so that there is sporadic firing of neurons to initiate the epilepsy. Also noted on pathology is synaptic reorganization, an attempt to reconnect the hippocampus with other areas of the brain, but it's not very effective to do that. The cause of hippocampal sclerosis is not absolutely known. There is an association with a history of febrile seizures during childhood. And this is not just 1 or 2 febrile seizures. I mean, almost all babies have febrile seizures at one time or another. But if they go into status epilepticus, then there is an association between that and developing hippocampal sclerosis later on. These are the things we look for on the MR images. Hippocampal atrophy. And fortunately, there are 2 hippocampi, so we can compare with the more normal side. Occasionally, mesial temporal sclerosis or hippocampal sclerosis can be bilateral. Look for hyperintensity on the T2 and FLAIR images. Temporal horn dilatation is a secondary sign. And then also look at the parahippocampal gyrus, because that may also be involved by the mesial temporal sclerotic process. Let's look at some examples. This young woman with epilepsy. On the T2 weighted axial images, there is some asymmetry with some hyperintensity within the right hippocampus. Note on the left side these focal areas of hyperintensity representing cysts within that hippocampal fissure. And those are just normal structures, just an anatomic variant, not to be interpreted as anything abnormal. On the FLAIR images, there is obviously abnormal signal intensity, hyperintensity within the right hippocampus compared to the left hippocampus. On the T2 weighted images, again, there is abnormal hyperintensity and atrophy, mild atrophy of that right hippocampus. And as we go further back, you can see we lose the internal architecture. You can't follow that superficial medullary lamina into the cornu ominis and to the dentate gyrus. And so abnormal hippocampal sclerosis. Looking at the parahippocampal gyrus, they look symmetrical. And so there's no atrophy of the parahippocampal gyrus. And so the term hippocampal sclerosis is appropriate in this case. Next case, another woman with chronic seizures. The T2 weighted axial images are normal. The sagittal images, the normal hippocampus on the left side, and then a markedly atrophic hippocampus on the right side. The amygdala appears normal on these images on both sides. And then we get the coronal images perpendicular to that hippocampus. And looking at those images on the right side, you can see the amygdala above the temporal horn, the hippocampus below the temporal horn, and there's abnormal signal intensity within that hippocampus. And as we go further back into the body, you can see marked atrophy of the right hippocampus compared to the normal left hippocampus. Also abnormal in signal intensity on the FLAIR image. And then if we look at the parahippocampal gyrus, and often to determine the volume of the parahippocampal gyrus, it's easier to look at the white matter component and assess the volume of the white matter component of the parahippocampal gyrus. And there's distinct asymmetry with atrophy of the parahippocampal gyrus on the right side. And so the term mesial temporal sclerosis is more appropriate in this case. The cause of epilepsy is not known, but it's some kind of degenerative condition of the hippocampus. How early can it develop? Presumably the patient is born with a normal hippocampus. How early can you develop temporal lobe epilepsy? Well, this 15-year-old girl had seizures since age 3. And on the images, it's clearly a picture of hippocampal sclerosis with high signal intensity on the FLAIR images, high signal intensity and atrophy on the T2 weighted images, comparing the right hippocampus to the left hippocampus, and also loss of the internal architecture of that hippocampus. All evidence for hippocampal sclerosis in this 15-year-old girl. This is an interesting case just to think about potential causes of hippocampal sclerosis. This young woman presented acutely with fever and seizures. And on the FLAIR, axial FLAIR images, there is abnormal signal intensity and anterior medially within the temporal lobe. On the coronal T2 weighted images, here is a parahippocampal gyrus, and there's distinct abnormality involving the hippocampus as well as the amygdala, hyperintensity, heterogeneous signal, and some swelling of the hippocampus. On the T1 weighted images, again seeing some swelling, edema in the area, a little bit of enhancement of the abnormality, no restricted diffusion, and clinically they made the diagnosis of HSV, herpes simplex encephalitis. So herpes simplex encephalitis, acutely presenting, involving the medial temporal lobe. And then interestingly, later on, she developed chronic temporal lobe epilepsy. And 7 months later, you can see atrophy of the hippocampus. And looking on the T2 weighted images, comparing the two sides, there's both atrophy of the hippocampus and the amygdala. And comparing the hippocampus on this image, on the right side and the left side, atrophy, high signal intensity of the anterior hippocampus. So, here we have a case of herpes simplex encephalitis that eventually resulted in a temporal lobe epilepsy. It's not the cause in all cases, but there possibly can be other viruses that can result eventually in hippocampal sclerosis. This woman had epilepsy since she was a child, and comparing the two hippocampi, the right one is normal, the left one just has an abnormal configuration. It has a more vertical orientation. And this is a malrotation of the hippocampus. It never fully developed. It never underwent the complete folding of the hippocampus to form the internal architecture of the hippocampus. And a malrotation of the hippocampus, which is a developmental abnormality, can be a cause of seizures. And this is the imaging appearance of that entity. Treatment for hippocampal sclerosis, the most common treatment is resection of the medial temporal lobe, and the surgeon generally will take off about 5 or 6 centimeters of that medial temporal lobe. And the surgery is quite successful. If the imaging shows hippocampal sclerosis, and that correlates with the clinical and the EEG and the MEG, the surgery can reduce or eliminate the seizures in about 90% of cases. So it's quite successful. Alternatively, the patient can receive stereotactic radiation or gamma knife treatment of the medial temporal lobe. Of course, the results are not immediate. It takes several months to see any response or reduction in the seizures. But just to keep in mind that this is one option that patients may receive radiation, and sometimes that's not included in the clinical history we're given. So just think about that if you see an appearance in this temporal lobe. I mean, this could be post-treatment. It could be some kind of a tumoral process. You just need to have that history. You can see the heterogeneity and the edema and the adjacent white matter. Heterogeneity, hyperintensity within the hippocampus and the amygdala, and some swelling in that area of the hippocampus. And then with contrast material, there is some enhancement around the perimeter, the axial and sagittal views, and also some hemorrhage in the region of the radiation. And of course, the radiation changes can evolve over many months. And so you just need to be aware of that if you're assessing the medial temporal lobe in patients who have temporal lobe epilepsy. That concludes the first part of this lecture.